හරි. පටන් ගමුද බේන?
පටන් ගමු සර්.
හරි. Okay. Right. So today the idea is to finish off gastroenterology. So currently, Samak, we have done cardiovascular, respiratory, and from today we finish the gastroenterology, hepatology thing as well, right? Right. And tomorrow we will make a start on nephrology. You'll probably be able to finish that tomorrow. So we are quite okay with timing. This kapada vibhaya patan ganne? When is your exam?
February 20th sir.
20th, right. Don't worry, we'll somehow finish it well before then. Satya karinga ibara kala denna. Yeah, sorry about yesterday. There are lots of things going on these days. Yeah. So, Hari. Okay. Right. So, the first question is on gastroesophageal reflux disease, right? Very common disorder, right? Very straightforward problem, at least when it's presenting to you for the first time. Right. So, now, gastroesophageal reflux disease is due to, pathophysiologically, due to a loss of tone of the lower esophageal sphincter, as you all know. And of course, there's a bit of overlap with surgery as well here. There are a lot of secondary causes of this condition, right? And what they do is they sort of relax the lower esophageal sphincter, right? So things like smoking, certain medications, they can relax the lower esophageal sphincter. But also remember that gastroesophageal reflux disease can also occur when there is increased pressure inside the abdomen, right? So pushing contents up into the esophagus. Like for example, in people who are grossly obese or have ascites, right? And also, hiatus hernia can also predispose to gastroesophageal reflux disease. So, decreased lower esophageal is a predisposing factor. It is not the only cause, but it is the common predisposition for GORD. Right. And as I've told you, in pregnancy, you get relaxation of the lower esophageal sphincter, and also because of the increased intra-abdominal pressure because of the fetus, that also promotes the reflux, right? So, is common in pregnancy is true. That is true. Right. Now, GORD can present in a variety of ways. The common thing is, of course, the dyspeptic symptoms that you've heard of, right? And that's the common presentation, right? Dyspepsia. But remember, sometimes these patients can present with respiratory symptoms, right? And especially this occurs when they lie down at night or go to sleep at night. They can get sort of micro aspiration, right? And that builds up over time, and they sometimes come to you with aspiration pneumonia. Also, an important point to mention here is that in patients with asthma, GORD is a well-recognized cause of refractory asthma, right? And one of the things that we actively exclude before going down the route of things like monoclonals and all these jazzy stuff. This can be a very simple precipitant for asthma as well, right? Again, because of this microaspiration into the respiratory tract. So it can have these sort of unusual manifestations sometimes. Now, GORD is a harmless disorder if you manage it well, but if you neglect it and it goes on for a period of time, the risk is it can cause adenocarcinoma. So what it causes is Barrett's esophagus, right? So this gastric metaplasia of the lower part of the esophagus, and that can go on to cause adenocarcinoma of the esophagus, right? So that is the main problem, right? The main complication of GORD in the long term, right? Right. Okay. Right, and this is a picture of sort of the gastric metaplasia of the esophagus. Now, this is a picture of sort of 24-hour pH monitoring. This is not essential for diagnosis because you can start treatment on a clinical basis. But this is useful, and Professor Nandadeva leads the team that does this at our university and the hospital. And you can do this, and this can be useful sometimes in refractory cases, and especially when you're planning surgery for refractory cases, 24-hour pH monitoring can be useful, right? But it's not required for the diagnosis. You can diagnose it on clinical grounds. It's not essential for the diagnosis. Mostly used in patients who don't respond to medical therapy, and especially in the context of surgical intervention, or planning surgical intervention, that is useful. Right. Okay. Any questions about that one? So straightforward thing, just off the notes, nothing complicated. Okay. Right. Now the next question is on Helicobacter pylori infection. Right. Now Helicobacter pylori is a very important pathogen, right, when it comes to gastrointestinal pathology. And it's important, these are all MCQ points. Helicobacter pylori is associated with a lot of peptic ulcers, but mostly with duodenal ulcers, right? So I won't go back to that, but I think somebody would have taught you the pathogenesis of duodenal ulcers and Helicobacter pylori. And this is one of the key causes, right? Almost 95% of duodenal ulcers are due to Helicobacter pylori. Gastric ulcers, it's not that well associated, so 70 to 80%, because gastric ulcers can also be due to things like medication, NSAIDs, steroids, right? That can also cause it. There is a link, but it's not as strong as with a duodenal ulcer. Also, we love to ask the other complications of Helicobacter pylori, and it is associated with gastric cancer and this funny type of lymphoma, which is called a gastric malt lymphoma, right? It's a lymphoma that occurs in the mucosa-associated lymphoid tissue in the stomach, right? So that is a special type of lymphoma, right? So these are common things that we ask you at MCQs. Unfortunately, again, I told you this true-false MCQs are useless nonsense, but right. It's well known that Helicobacter pylori has an association with poor socio-economic status, right? And it is commonly seen in areas of overcrowding, right? When there are areas of overcrowding. And the reason for this being that this is has a fecal-oral transmission. So the organism has a fecal-oral transmission, right? So associated with poor socioeconomic status is right, and is considered a causative agent for gastric malt lymphoma is also true, right? Now, this is a little bit about the organism, again, might be useful for certain MCQ points. The first thing is obviously it is a gram-negative bacillus, right? And remember, this organism is adapted to live in the extremely acidic stomach, extremely acidic environment of the stomach. The ways it does is, one, it lives very deep in the gastric mucosal barrier. So it lives very deep in the mucus, right? Buried in the mucus, right? And closely adherent to the gastric epithelium. So it's buried inside, right? Is buried inside. And it's mostly seen in the antral region of the stomach, right? Mostly the antral region, not the cardia. Cardia is more proximally. So it's antral, closer to the duodenum, distal part of the stomach that you get this organism, right? And it is buried deep in the gastric mucosal barrier. So it survives this acidic, extreme acidic environment. Another thing that this fellow does is it has urease enzyme and can convert urea into ammonia, right? So ammonia sort of is able to neutralize the acidic microenvironment, right? Because of the urease within the organism, right? And this is sometimes we use this principle for a test as well, which we'll talk about in a minute, right? And also produces this organism also produces these various toxins like CAG, VAC, and things like that as well, which are pathogenic, right? So let's go back to that MCQ question number 2. So first one, associated with poor socioeconomic status, I told you that was true, and it is a fecal-oral transmission. gram-negative bacillus. So it is gram-negative bacillus, not a gram-positive bacillus, but it is deep in the mucosal layer and adherent to the gastric epithelium. Most commonly found in the antral region of the stomach, is considered as a causative agent for gastric malt lymphoma. Is also true. Right. Now, how do you diagnose Helicobacter pylori infection? Right. Now, this slide gives you the common tests that we do. This is again a very famous area for MCQ, right? Even in surgery, you can get asked about Helicobacter pylori. So it's a reasonable thing to study up about it. So there are several tests that we use to diagnose Helicobacter pylori infection, right? One of them is this gold standard urea breath test. That is a gold standard urea breath test. This slide sort of gives you a summary of what that is. Essentially, it is a carbon tagged urea, which you can detect when the bacteria breaks it down with that urease enzyme. Remember, the bacteria has a layer of the urease enzyme. It breaks down the urea, and you can detect this radioactive carbon in the breath, right? So it has a simple sort of principle to it. We don't routinely do this in Sri Lanka, however, but it is considered as the gold standard test for Helicobacter pylori, right, and the most accurate test. Another test that we use is and this is commonly used, is the Helicobacter antigen stool test. So it is an antigen test in the stools, and you use a little bit of stools to test the antigen, right? So that is the more commonly used test, one of the commonly used tests, right? Antigen test, right? Now, an important MCQ point about both of these tests is that these tests can be negative for obvious reasons if a patient has been on antibiotics, right, or has been on PPIs, right. These tests can be negative because these suppress the bacteria, right, and that can lead to negative results, right. Okay. Now, we also do, hold on. Right. Right. Okay. So these are the standard tests that we use to diagnose the organism, right? Fine. We also use serology tests sometimes. They're very cheap and frequently available, right? Yeah, they're frequently available, these serology tests, antibody tests. But again, remember, like all antibody tests, you can't diagnose it with a single test, right? And you have to do a paired test to see if there's a rise in the antibody titer, right? So you have to, do that as a sort of a paired test, right? Rise in the antibody titer, right? But of course, if the antibody is negative, you can almost exclude it. But if it's positive, you have to repeat it to see if there's a rise in the antibody titer, right? And also remember, the antibody test is not affected by antibiotics and PPI, so it's not affected by medication, right? Now, also, these are the sort of non-invasive tests. So always remember, what we consider is always try to do a non-invasive test, right? There are invasive tests like the CLO test, where you take a little bit of the biopsy and put it on a slide, and that also tests the urease activity. That can be used also, but we try to diagnose it with non-invasive tests, right? Non-invasive tests. Okay, right, right. Yeah. So Nipun, you can say it is also gold standard to actually demonstrate the organism on a biopsy sample, but that's not very often done, right? Very, very rarely done. It's very difficult to stain the organism on the biopsy. Right. Sorry, I'm on call today, but right, okay, that's fine. Right. Okay. Right. So, ekahari. So, try to go for a non-invasive test. Most of the time, antigen test. Urea breath test is not done in Sri Lanka, at least as far as I know. Serology is also useful, especially if their patient has been recently been on medication, right? Within 4 weeks of antibiotics, right? Or 2 weeks of PPI within that period, right? Again, antibiotic නවත්තලා සති 4ක් ඇතුළත, right? That's what it means. Somebody had asked that question. So antibody tests are useful, but they always need a paired sort of sample. Paired sample. Right. Okay. Right. So let's so antibody testing is the gold standard කියන එක වැරදි. That is wrong. Any questions about question number 2 and any of these tests, ළමයි? And usually, if these tests lead to negative Helicobacter pylori, you usually almost never repeat the tests, as you can see in this algorithm, except for this box that I'm circling around. Only retest for HP if any of those conditions, right? But otherwise, we don't retest, because these tests almost have very good negative prediction, right? Right. Any questions? So Lankawe, we do the antigen test and the serology. Those are the two things we do, and also the invasive biopsy test on that's called a flow test. Those are the things that we do in Sri Lanka. Right. Okay. Right. So question number 3 is also on peptic ulcer disease. So this I told you was false. Neither. Helicobacter pylori is associated about 70 to 80% of gastric ulcers, but almost 95% duodenal ulcers. Right. Now, in endocrinology, we'll talk about this sort of Zollinger-Ellison syndrome, which is a gastrinoma, and that can cause recurrent duodenal ulcers. That's true. Now, traditionally, duodenal ulcers are present with nocturnal pain, which is periodic, right? කාලයකට තියෙනවා, කාලයකට නැහැ sort of story, right? Periodic nocturnal pain is the typical presentation of duodenal ulcers, right? Whereas gastric ulcers present mostly when the patient is eating something, right? This is not always correct, but the textbooks describe it in this way, right? Sorry. Right. Now, how do you treat peptic ulcers? In most cases, lamai, you treat them with proton pump inhibitors, right? Most cases, peptic ulcers, you treat with proton pump inhibitors, and that causes an irreversible inhibition of the H plus K plus ATPase, right? So that is right. Now, if your patient has positive Helicobacter pylori, then the story is different. So if you have proven that the patient has Helicobacter pylori, then you go for an eradication regime. And please make sure you remember this, make a best response nitara mahana deyak. Without confirmation of Helicobacter pylori, it is not recommended, underline the word not recommended, to start this eradication regime, right? You have to show that there is presence of Helicobacter pylori with any of these tests, right? So either a urea breath, stool antigen, a paired serology test showing a rise in the antibody titer, right? Or an invasive test. There has to be some sort of confirmation before you start the eradication. I know in Sri Lanka that people just give this without testing. That is not recommended. Exam make you need to know what is recommended and you have to confirm Helicobacter pylori. So that's always called the test and treat strategy, right? Why? Because if you just blindly, you should never ever give blind antibiotics for anything, right? This is a very bad habit in Sri Lanka, which you should change when you become doctors. Horrible. You can just buy antibiotics out of the counter or over the counter and you take antibiotics for every damn thing under the sun. In the UK, it is the complete opposite. ඇත්තටම ලෙඩක් තිබුණත් antibiotic එකක් ගන්න බෑ මෙහෙ. That is a complete 360, right? And I don't know whether you have heard on the news, lots of children here recently died from scarlet fever, right? Now scarlet fever in Sri Lanka is unheard of because ඕනම උගුරේ අමාරුවකට we give antibiotics. Here ඇත්තටම බැක්ටීරියා උගුරේ අමාරුවක් තිබ්බත් antibiotic එකක් දෙන්නේ නැහැ. So people die of scarlet fever. So it's a two extreme situation in the two countries. Right, but anyway, whatever it is, blindly do not give antibiotics. So same principle for Helicobacter pylori. Now I have given you the regimes that we commonly use for this eradication process in this slide, right? මේවා කටපාඩමින් දරගන්න ඕනේ නැහැ, but just remember that there is a right PPI, right? PPI plus antibiotics, right? So PPI plus 2 antibiotics. And if there's penicillin allergy, use clarithromycin instead of amoxicillin, right? So that is the regime that we use. Okay. And of course, if the patient doesn't respond to that, then there are various other regimes that people introduce, not important for a final MBBS undergraduate level. You should know the first line things and always remember test and treat. Confirm and then treat. Right. Any questions? So, අපි බලමු MCQ එක අන්තිම එක triple therapy blah blah blah. Not all patients with peptic ulcers. Ne? You have to have a confirmation of Helicobacter pylori always to start that. I know in Sri Lanka it doesn't happen like that, but you should know the right correct thing. Hari. Okay. Any questions about that? Am I? That's question number 3.
Sir, is the triple therapy for 1 week or 2 weeks?
1 week තමයි recommend කරලා තියෙන්නේ. Yes, just 1 week. Yeah. But then if it doesn't respond, then you have to do more weeks. Right?
Okay, sir.
Yeah. Hari. Now, the next question, now we are moving on to the intestines and we're talking about acute gastroenteritis. Now, unfortunately, even in the medicine paper, we ask these boring microbiological details, which you would have studied a lot in your foundation module, but completely forgotten now. But පොඩ්ඩක් medicine වලටත් කියනවා මම පොඩි වගුඩයකට උනත් දාලා තියෙනවා for you to sort of to help. Especially E. coli, there are various strains of E. coli, right? That I have given. He will come back to the slide. Right. Now, gastroenteritis can exist, right? Gastroenteritis. Okay. So, gastroenteritis can exist in, they sometimes present with sort of a watery diarrhea or sometimes they present in dysentery. So dysentery, as you know very well in pediatrics, is a sort of a blood and mucus diarrhea. Now, there are certain organisms that cause dysentery and Shigella is one of them, right? Shigella is one of them. There are certain forms of E. coli, especially the entero-invasive strain of E. coli that can cause dysentery. Remember MCQ වලට අහනවා. හරි. So Shigella, the entero-invasive strain of E. coli, and also amoebic dysentery, right? Amoeba can also cause dysentery. So Shigella causes dysentery. And there are some Salmonella strains also that can cause dysentery. Not all of them, some Salmonella strains. Right. Okay. Now, Salmonella, as I told, commonly causes sort of a watery diarrhea, but can cause dysentery. And in the Salmonella group also, there are various types of Salmonella, right? And remember, Salmonella infection is sort of associated with dairy related, where poultry, eggs, right, milk, that sort of setting, you get a lot of Salmonella infection, right? Salmonella. So that is a sort of setting in which you get Salmonella, and also similar for Campylobacter. Campylobacter and Salmonella occur from the same sort of epidemiology, right? Or farm, dairy, sort of chicken, that sort of thing is where you get the Salmonella and the Campylobacter from. Now, of course, the most famous Salmonella is Salmonella typhi, right? එතකොට Salmonella typhi there is a different illness. Salmonella typhi or typhoid fever is a different illness. ඒ කියන්නේ නිකන් මේ කියන දේවල් ටික විතරක් චුට්ටක් මතක තියාගන්න. Salmonella typhi, the typical course of typhoid fever is usually around 4 weeks. That is the natural history of the infection, right? So over about a 4-week period, right? Initially, they get a bit of constipation and something called a pea soup diarrhea, right? The color is a greenish color diarrhea, right? Textbooks will typically describe this stepladder fever in typhoid fever, right? And stepladder fever. දවසක් විතර එක ගානක තියෙන දවස් දෙකක්, then it goes up and then stays another, right? So it is a stepladder fever that they get. Stepladder fever කියලා කියනවා. And of course, as you know, the typhoid organism reinfects the gut. It goes into the gallbladder and reinfects the gut. So most of the complications like intestinal perforation can occur in the sort of 3rd week. So those are the important points about typhoid fever, right? So intestinal perforation. And as you know, very famously, this organism can remain dormant in the bile, right? And all of you have heard of the typhoid Mary story, right? So Campylobacter infection is acquired by consuming poultry, that is right. Salmonella infection can be complicated for cholecystitis, again because the organism is dormant in the biliary system, and this is especially Salmonella typhi, that is the thing here, right? Now, here in this slide, you can see that, yeah, so that's what I said here. First constipation and then they get a diarrhea. Yeah, that's what I said. Right. So, E. coli, there are various strains. So, MCQ වලට අහන ටික තමයි මම මේ slide එකේ දාලා තියෙන්නේ. Right? So, it's all, I told you these slides, just go through them about a week to the exam and you should be perfectly fine for the MCQ. Right? So, I already talked about this entero-invasive E. coli, which causes sort of a dysentery-like picture. But there are various other types. Famous one is this enterotoxigenic E. coli, which produces a toxin. This is like cholera wage toxin එකක් cooking හැදෙනවා. And that is the cause of traveler's diarrhea. Traveler's diarrhea. That and this, right? But mostly enterotoxigenic E. coli, right? A very famous strain of E. coli is this enterohemorrhagic E. coli. ඔකත් නිතරම MCQ වලට අහන එකක්. It can also cause a dysentery-like picture, but the famous MCQ point is HUS causes HUS, and this is the exact strain that causes the HUS, O157H7, right? That is the famous strain that causes the HUS. So that's because of that reason, it is a typical MCQ point, enterohemorrhagic E. coli, right? So entero-invasive, mainly dysentery. Enterotoxigenic is sort of traveler's diarrhea when somebody goes overseas. Say for example, UK and India, that is an enterotoxigenic E. coli. And this famous enterohemorrhagic E. coli causes HUS, hemolytic uremic syndrome. Right, so make a varadi. And I'm not only going to talk about gastroenteritis and ORS. In pediatrics, you get an overdose of that. So I'm not going to go into that. Right. Any questions about that? Question number 4.
Sir,
Hmm.
so if they said enterohemorrhagic E. coli will cause a bloody diarrhea, is it true?
That's also true. Yes, that's true. Yes.
Thank you, sir.
And HUS is the famous manifestation of that. Well, right. Okay, right. Now this MCQ, question number 5 in your paper is on chronic diarrhea. Now before we do the MCQ, this is something that can be useful. I may not have discussed this during your appointments. And we usually don't give you chronic diarrhea patients for long cases. But very well, the question will be very, very simple. Essentially, you need to know when somebody comes with chronic diarrhea, usually diarrhea for more than 6 weeks, whether they have a small bowel origin or a large bowel origin diarrhea. That is the main thing that you need to know clinically, right? Whether is it a small bowel or a large bowel. Now, obviously, because the water content is higher in the small bowel, they usually get a very watery, large volume diarrhea, right? That is a typical story. A very frequent water content high diarrhea, right? But the important thing to remember is if the small bowel is involved only distally, they get a special type of diarrhea. So most of the time it is a frequent, watery, large volume diarrhea. But when it only involves the distal ileum, they get a very specific clinical syndrome, which is steatorrhea. Right? So very specific clinical syndrome of steatorrhea because of the fat malabsorption. Right. So these are the features of small bowel diarrhea. Usually there is no blood or mucus and no rectal symptoms, obviously, right? A patient with small bowel diarrhea can have referred pain, and you know the small bowel is referred around the umbilicus. So they will have intestinal colics, colicky type pain around the umbilicus, right? Right. And also, obviously, you know that the small bowel is involved in absorbing a lot of nutrients, right? Proteins, right? Digestion is essential for lots of things. So they will have features of malabsorption. Right. So that syndrome, either a watery, high volume sort of diarrhea or steatorrhea without any rectal symptoms, no blood mucus, with malabsorption, weight loss is another thing, right? So malabsorption, weight loss, vitamin deficiency, that is suggestive of a small bowel origin. Right? And they can also have pain in the umbilical region. Large bowel diarrhea, the story is different. They have comparatively small volume, but mucoid stools. That is an important thing, right? Mucoid stools. And also they can get blood in their stools as well. So it's a mucoid blood related stool. Doesn't have there is no large volume, right? Large volume product volume mucus, right? Mucus is the feature, mucus. And then they also have pain, abdominal pain, and again referred pain from the large bowel goes into the hypogastric region. So they have sort of hypogastric pain, right? Again, colic, because the bowel is a hollow structure, they get a colicky type pain. So this sort of thing you have to know. Right, and we can ask this in an MCQ as well, right? The difference between when you have somebody with chronic diarrhea, the first thing to do is, okay, is this a small bowel or a large bowel origin? That is the thing that you have to determine. Right. So the first question, frequent large watery stool is more suggestive of a large nerve, it is more suggestive of a small. Steatorrhea is not cecum but distal ileum. Right. Okay. Right. Now, then once you determine whether it's a small or large, you can also look for a mechanism-based approach of the diarrhea as well. So the first thing is anatomically, you determine is this a small or large. And then the next step is to using a mechanistic approach, mechanism එක අනුව the features can change, right? So for example, some people have a secretory type diarrhea. A secretory type. This is very well seen. You would have heard in surgery about these, like VIPoma, carcinoid. These are hormones, these are tumors that produce hormones that increase the intestinal secretions. VIPoma, carcinoid, these sort of things. So they have massive amounts of secretions and water, large amounts of watery stools when the pathology is secreted. And fasting doesn't change the amount of diarrhea, right? So that is the type of diarrhea you get in things like VIPoma, carcinoid syndrome, right? Then you have things like osmotic diarrhea, osmotic. If you take laxatives or something, or abuse laxatives, and people with various eating disorders sometimes abuse laxatives to lose weight, right? So there you get again loose stool, watery stools, but it stops when observed fast එකක් වෙලා නතර වෙනවා, because they will take the damn thing, right? So if you observe fast, there is no diarrhea, right? Then of course you can get inflammatory diarrhea. There are mechanisms. So inflammatory diarrhea, infection වෙන්න පුළුවන්, inflammatory bowel disease could be, right? And there they get fever, blood in their stools, right? We already talked about malabsorptive diarrhea, especially distal ileal disease, right? Then finally, diarrhea can be due to dysmotility, classically seen in things like diabetes and other autonomic neuropathies. And there the feature is nocturnal diarrhea. So certain pathogenic mechanisms have certain features like secretory, osmotic, inflammatory, and dysmotility, right? Right. So the third MCQ is pancreatic calcifications increase the possibility of a malabsorptive cause. Surgical, you know this, chronic pancreatitis can cause malabsorption, right? Fasting reduces the frequency of secretory. No, it is a tumor. It is always secreting the VIP or the carcinoid stuff. So that does not affect the frequency of diarrhea, secretory diarrhea. We'll talk about Crohn's and, this is correct, but we'll talk about Crohn's and ulcerative colitis in a minute, right? Okay. Any questions about that one? Right, now this is just again something for completion. You suddenly have these things popping up. Irritable bowel syndrome, right? Wage දේවල්, right? You're not ready for it, but I just want to it. You can get these sort of questions also. So irritable bowel syndrome is diagnosed based on this criteria, which is called the Rome 4 diagnostic criteria, right? And remember, irritable bowel syndrome can be constipation predominant, right? Diarrhea predominant, or mixed, right? Samaka dysmotility and it's sort of a overflow accumulation in the night sort of thing. There is a relatively complicated mechanism, but yeah, don't worry too much about it for the moment, right? So we're talking about irritable bowel syndrome, that is can be constipation or diarrhea, is alteration of bowel habits essentially. It doesn't always have to be diarrhea, right? And they get a lot of sort of defecation related abdominal pain. That is another common feature. However, I have to tell you that, I'm going to stop showing these pictures of stool, is that irritable bowel syndrome, the key thing to remember about it is a diagnosis of exclusion, always a diagnosis of exclusion. When somebody has altered bowel habits, you have to exclude everything, including cancer and things, before you diagnose irritable bowel syndrome. So it is a diagnosis of exclusion. So diagnosis based on the Rome 4 criteria, that is correct. It's more common in patients with fibromyalgia. So we see that this syndrome of IBS is associated with fibromyalgia, depression, right? There is a psychological sort of history super added with it, right? So that is true. Now, looking at the risk factors for IBS, it is well recognized that acute severe intestinal infection can be a risk factor. Right? So, in the past, if they have had a acute severe enteric infection, that is recognized as a risk factor for IBS. But remember, that's a risk factor. But it can occur in association with these other sort of fibromyalgia, depression, psychological stress, that sort of thing is associated. Right. Now I told you that IBS always is a diagnosis of exclusion. That is very important. And if you have weight loss, you can't diagnose IBS. So the risk factors for cancer, like weight loss, anemia, right, bleeding, that sort of thing is cancer, or there's something else going on. So if there's weight loss, always think of something else, not IBS. That also highlights that this is a diagnosis of exclusion. Right. Several medications are used in treatment of IBS, but lots of it is non-pharmacologic and lots of behavioral and dietary changes, right? Low FODMAP diet කියලා එකක් තියෙනවා ඒක අහන්න පුළුවන් ඒක මෙතන තියෙනවා what it stands for හරි පල්ලෙහා but also there is a lot of psychological support, exercise, lifestyle modification as well. But you can try lactose restriction, gluten restriction, fiber diet, right? And this low FODMAP diet, which is this fermentable oligosaccharide, etc. But there are lots of other pharmacological treatment options as well. Pharmacological treatment options with TL. Right. Okay. Right. Any questions? Okay. Right. Now, next we move on to inflammatory bowel disease. Now again, this is a sort of a galin kurullo dennik sort of thing. In surgery also, you can get a case, sort of a MCQ on irritable bowel syndrome. I don't know whether they give long cases for surgery, but of course it can appear in a discussion of blood and mucus diarrhea neither in surgery. Right. Now, the first thing, it's very easy to set an MCQ comparing the two. So, ulcerative colitis and Crohn's comparison. And I have given you some slides which give you all that sort of information in a comparison. Right. මෙතන වැදගත් දේවල් කීපයක් තියෙනවා. One of the MCQ again, right, is that, right, ඔය අපි හරිම ආස අහන්න එකක් තමයි smoking. We love to ask this. So based on epidemiological evidence, smoking may prevent ulcerative colitis, right? That is something that we love to ask in MCQs. Don't ask me the reason for that. It's all based on this long-term epidemiological cohort studies, right? And that's something we love to ask in MCQs. Now then, looking at the pathology of Crohn's versus ulcerative colitis, there are lots of differences. Right. Now, in Crohn's disease, the story is that it can involve any part of the gastrointestinal tract. Any part of the gastrointestinal tract, from mouth to anus, it can affect. Right? But it doesn't affect it continuously. Right? There are skip lesions. So the typical story is There is an affected area and a normal area. Affected area, normal area. So even though it involves the whole gastrointestinal tract, it doesn't involve it in a continuous manner. දිගටම involve වෙන්නේ නැහැ. Right? It is a sort of a skip lesion involvement. However, when the intestine is involved, it has a transmural, full thickness involved. Right. So that's the story of Crohn's. Ulcerative colitis, the story is the disease is limited to the large intestine, right? But can involve a little bit of the ileum as well, right? Because the disease can spread through the ileocecal valve. So you can have a little bit of ileal disease, but it is almost 99% large intestine, right? And it has a continuous involvement. When it is involved, it has a continuous sort of involvement. Right? Continuous involvement. Okay. Right. Now, certain special things you see in Crohn's, like perianal disease is quite common, and this perianal abscess, fistula, those sort of things are commonly seen. Right. අනිත් එක because the whole thickness is involved, ඒක පැලෙනවා වගේ. Mucosa has a cobblestone appearance, and you have these very thickened walls, which can cause strictures and adhesions. Thickened walls here. Right. So that is the story. So remember, in Crohn's disease, mouth to anus can be involved. Skip lesions are the feature, and the whole thickness of the intestine is involved. So it can cause these strictures, adhesions, because the whole thickness is involved. And also the appearance is sort of cobblestone, පැලිලා වගේ තියෙන්නේ mucosa එක. Right. And that is the story there. And perianal disease is very common, right? Perianal fistulae, things are common. Ulcerative colitis, the story is completely different. And special to ulcerative colitis, it's a very inflammatory type disorder. Erythematous inflammatory type disorder. Lots of neutrophils hanging around. Right. So let's talk about this MCQ. And we'll revise some of the things that we have just mentioned and summarize. True or false regarding the features that suggest a diagnosis ulcerative colitis over Crohn's disease? Blood and mucus diarrhea clearly suggests ulcerative colitis. Right. It's a more inflammatory thing. And it's large bowel nisa, you get blood and mucus diarrhea. Right. In Crohn's disease, they have extensive perianal disease. That is true. And also remember, Crohn's disease is a small, so they can present with small intestinal diarrhea, malabsorption, but the common thing is the perianal fissures, fistula. You see plenty of this in surgery, I'm sure. Right. Crohn's disease is transmural involvement, but ulcerative colitis is just superficial mucosal involvement. Right. Granuloma in Crohn's disease, not in ulcerative colitis. Right? In ulcerative colitis, lots of neutrophils tama tiyenne. Crohn's, you get the granuloma. Yeah. Sorry, second one is false. Sorry, mark kara. Yeah, second one is false. So usually, Rehani, Crohn's does not cause blood and mucus diarrhea. It can, but make a more suggested so you have blood and, if you are considering IBD, if you have blood and mucus diarrhea, you would bet your money on it being ulcerative colitis, right? That is the answer. That is the justification of the answer there. Yeah. Right. So transmural involvement with granulomata in histology is seen with Crohn's disease, not with ulcerative colitis. Right. Now I told you the ulcerative colitis is a very inflammatory, nasty disorder. And sometimes it can cause dilatation of the large bowel, right? And that is called toxic megacolon. So ulcerative colitis is known to present with toxic megacolon. Crohn's because of the thickening, adhesions, intestinal obstruction, right? But ulcerative colitis is a very inflammatory, aggressive thing You can get colon dilating or you can get perforations of the colon. These are nasty disorders, right? So that toxic megacolon is a feature of ulcerative colitis. Elevated ESR can occur in both, so it doesn't differentiate ulcerative from Crohn's. Right. Any questions on this one? 7? ප්‍රශ්න මොනවා හරි තියෙනවද? Okay, no problems. Good. Right. So a few more MCQs, and here we are talking about ulcerative colitis. Smoking is a recognized system. අකෝ හරිම famous point එකක්. Smoking වලට prevent කරන්න පුළුවන් කියලා. There is epidemiological evidence. Right. These are cohort studies. Cobblestone appearance එක මෙන්න මේ වගේ පේන්නේ, right? So in this picture it is shown the cobblestone appearance. And that is Crohn's, right? පැල්ල වගේ රීරි වගේ තියෙන, that is Crohn's. Right. Now remember in these inflammatory bowel disorders, right? So this is a ulcer, you can see the ulcers and superficial sort of thing, right? Whereas in Crohn's you get this nice sort of, it's like a පැල්ල වගේ mucosa එක, that is called the cobblestone appearance. Now in these inflammatory bowel diseases, you can get extraintestinal syndromes. Here I have given you pictures of some. On the left is pyoderma gangrenosum. On the right is erythema nodosum. And there are lots of other things like sacroiliitis. You can get a sort of a, I told this in the long case discussions, spondyloarthritis picture in association, right? තව තියෙනවා, you get uveitis is also quite common as an extraintestinal manifestation. හරි? And there is a biliary one මේ ටික ඔක්කොම මතක තියාගන්න ඕනේ, called primary sclerosing cholangitis. හරිද බලන්න? So uveitis, they can get a spondyloarthritis, primary sclerosing cholangitis, and the skin manifestations are the ones I just showed you, the pyoderma gangrenosum and the erythema nodosum. So sacroiliitis is a recognized extraintestinal manifestation. There is a slight difference in the two also. එකක වැඩි චුට්ටක් අනිත් එක එහෙම ඒවා ගැන වැඩි ඔළුව විකාර කරගන්න යන්න එපා. Generally this can occur in anything, any of the two conditions, right? Hari. Okay. Now I told you that that the feature of ulcerative colitis is a very nasty inflammatory type disorder කියලා මම කිව්වා ඔයාලට නේ. Inflammatory nasty disorder. So the problem is that it can present with ASAC, acute severe ulcerative colitis, right? And that sort of is really bad. It can lead to toxic megacolon, perforation and death if you have acute severe ulcerative colitis. Now this is a scoring system we use to diagnose acute severe ulcerative colitis. ඔකට කියන්නේ මේක කටපාඩමින් දැනගන්න අවශ්‍ය නැහැ. It's called true love and wit. Right? True love and wit criteria කියලා ඔකට කියන්නේ. And that is how you diagnose acute severe ulcerative colitis. Right? True love and wit. මම ඔක්ස්ෆර්ඩ් එකේ උන්ට නිතරම බයින් එකක් තමයි උන් මේක දන්නේ නැහැ කියලා, because Sydney True Love was a professor at Oxford. එයාගේ නමින් වාට්ටුවකුත් තියෙනවා. මෙහෙ උන් ඉතින් ඔහොම එකක් අහලවත් නැහැ. හරි? So this is the true love and wit criteria, right? For acute severe ulcerative colitis. This is a very old criteria, but it's still very valid. Right? Still very valid. Right. Then ලොකු සීන් එකක් දැනගන්න ඕනේ. If you diagnose acute severe ulcerative colitis, that is a medical emergency. Medical emergency. you have to send off stools for microbiology and C. diff. That is a very important thing. Kala CMV, api balanawa මේ patients with ulcerative colitis, they are on immunosuppression. So if they present with ASUC, acute severe ulcerative colitis, they can be CMV also positive. So ඒවා බලන්න ඕනේ. Clostridium difficile is an important organism also to test for. And the treatment of acute severe ulcerative colitis is intravenous steroids. Right? Intravenous steroids. That is the treatment. Nothing else. Intravenous steroids. Right? And you also need to scan them for evidence of toxic megacolon. Right? Take a CT again, ලස්සනට අඳුර ගන්න පුළුවන්, if not X-ray. Right? So steroids are the treatment of choice. Number one. Right. If steroids do not work, number two treatment option is infliximab. Right? So that is the treatment option. Number two is infliximab. If steroids don't work, infliximab doesn't work, they will need surgery, and you sometimes need to take the intestine out and put a colostomy. Right? So part of the intestine අයින් කරන්න වෙනවා if it doesn't respond to steroids and infliximab. So surgical is the third option. Right. So it's a medical emergency. Send off their stools for various things. Image them to look for toxic megacolon, X-ray or CT scan, and steroids are the first line treatment intravenously. Right. Okay. Rarely api cyclosporin පාවිච්චි කරන එක වැඩිය. And this is a X-ray of toxic megacolon. මේ බලන්න මේ dilated colon එක පේනවා. Right. Okay. Any questions? අපි ඉතුරු තියෙනවා ඒකේ. So I would like to say no patient prognostication බොරු කතාවක් ඒකේ බලන්න ඕනේ whether there is toxic megacolon. IV infliximab is used as a second line to steroids when we are managing acute severe ulcerative colitis. Right. Any questions about that? So that is question number 8. So Crohn's වල acute flare එකකදී they will have mostly නිකං diarrhea, watery diarrhea, rarely blood and mucus bloody diarrhea එකක් එන්න පුළුවන්, but most of watery diarrhea, they have systemic symptoms ඒ වගේ. Right? In acute severe ulcerative colitis, they come with this blood and mucus diarrhea. Now Crohn's වලත් you use immunosuppression, but the management of Crohn's is relatively complicated, and I am not going to go into that. ඒක කොහෙද Crohn's එක තියෙන්නේ කියන කනුව චුට්ටක් treatment එක වෙනස් වෙනවා. So yeah, that is very specialist gastroenterology. ඒ gastroenterology වලත් ඔය luminal කියලා වෙනම දැන් තියෙනවා කෑල්ලක්. So even in gastroenterology liver බලනියු වෙනම ඉන්නවා, intestine එක බලනියු වෙනම ඉන්නවා. So it's a very specialist area. So don't worry about that for the moment. Right. Okay. Right. Then the best response MCQs are bloody easy. Make ඔක්කොම දන්නවා what is this diarrhea, bacillus cereus, Chinese rice story. ඔක අහන්න දෙයක් නැහැ. remember bacillus cereus is a preformed toxin, so කාපු ගමන් යනවා අනිත් පැත්ත. Blah blah blah. So this again we have discussed in detail. Reflux එක dysphagia આવොත් we have to always think about Barrett's esophagus as the cause. Then recurrent reflux causing intestinal gastric metaplasia of the esophagus, and that causes adenocarcinoma. මේ කතන්දරේ බලන්න මොකද්ද මේකේ තියෙන්නේ. So there is typical story, diarrhea තිබුණා, හරි. ඊට පස්සේ දැන් මොකද වෙලා තියෙන්නේ? There is low hemoglobin, point එක ගියා, sorry. So there is low hemoglobin, low platelet, high urea, fragmented red cells, right? This is HUS. Okay? We'll talk about HUS in a little bit more detail when we do hematology. මම කියෝක හැම වෙලේම අහන එකක් ඕන තරයකදී අහනවා ෆයිනල් එකෙත් අහනවා MRCP එකෙත් අහනවා හැම ලැබ් එකම අහනෝක that is if you do medicine that is MD part 1 එකෙත් අහනවා this H157H5 is equalized HUS. Hari. So that is another specialty done. Right. Okay. Right. Any questions? So our gastrohepatology done now, right? Right. Okay, and මේවා කරන ගමන්ම study so that at the end you will realize about a week to I will finish this in time, don't worry. කොහොම හරි කරන්න. But yeah. Okay. Any questions? Are there any other organisms in Chinese food? Bacillus cereus තමයි Chinese food දුන්නොත් දෙන්නේ. It's a preformed toxin. And an uncooked or partly cooked rice වල තමයි ඌ survive වෙන්නේ. Right? And the toxin is there as well. It's a preformed toxin. Question 6 වල මොකක්ද අහලා තියෙන්නේ? Yeah, so 5-HT antagonists are used in the management එක හරි. Yeah, that's true. 5BS. Extraintestinal, so any of the extraintestinal manifestation can flare up during IBD flare. විශේෂ එකක් නැහැ. So ulcerative colitis maintenance therapies with yes 5-ASA තමයි ගොඩක් වෙලාට, but during acute severe ulcerative you stop that and start the patient on steroids intravenously. Some people maintenance වලට we give drugs like azathioprine ඒ වගේ immunosuppressants උත් දෙනවා. හරි, but again this is a bit too complicated for undergraduate. කසුන් අහලා තියෙනවා PBC ගැන වැඩි අහන්නේ නැහැ. The only thing you need to know is it causes usually affects middle-aged females, PBC. Also, you have a long gap between pruritus. It starts off with pruritus. සමහර මාස ගණන් pruritus තිබිලා they get a cholestatic jaundice and cirrhosis. The anti-mitochondrial antibody is positive, right? Anti-mitochondrial antibody is positive, and the treatment is with ursodeoxycholic acid. That's it. About PBC. Yeah. So why do you send clostridium and CMV? Yes. So because it can contribute to the exacerbation, or it might be the cause of the exacerbation as well. That is why. Right? And if you miss those and you immunosuppress the patient is going to die of overwhelming C. diff or CMV infection. Okay. Right? And the treatment for C. diff is vancomycin or metronidazole. Right? Calprotectin is sort of an inflammatory marker that is positive in ulcerative colitis. Right? Fecal calprotectin. It's sort of sensitive for inflammation of the stomach, gut mainly in, yeah. හරි. චමත් හරිද එහෙනම්? හෙට නෙෆ්‍රොලොජි කරමු. වෙලාව ඒ වෙලාවම වගේ
ඔව් සර්. අවුලක්
පුළුවන් නේ. හරි. රයිට්. කල මං හෙට කියනනම් ලබන සතියේ දවසක් මොකක් හරි කොහොමද කරන්නේ කියලා. හරි.
හරි සර්.
හරි. Okay.
Thank you sir.
Right?
Thank you, sir. Thank you, sir.